are being recorded.
Great, thank you. My name is Ethan Baldwin. I'm a health policy analyst with the Division of Financial Regulation, and today's meeting is for our Prosthetic Orthotic Rulemaking Advisory Committee. The date's July 31st, 2025, and the time is 10:30 a.m. So we'll go ahead and start with introductions. Let's start with DFR staff on, and then we'll go to the rest of the group.
I suppose I can start. I'm Jesse O'Brien. I'm the manager of the policy section with the division.
I am Karen Winkle, the rules coordinator for the division.
This is Pramila Reddy with Oregon Department of Justice. I'm counsel for the Division of Financial Regulation.
All right, thank you. I think that's all of our folks. So we'll next go to people who are, let's go with people who are formally invited to the RAC, and then we can do interested parties after that. So if you've gotten a formal invite, go ahead and introduce yourself.
Hi, good morning.
Sorry.
Good morning. My name is Antoinette Iwachi, and I'm the Senior Public and Regulatory Affairs for Cambia Health, also known as Regents Blue Cross Blue Shield of Oregon. And we also have the Bridgman Health Plans. And I'm a RAC member. Thank you.
Hi, I'm Terry Cuffle. Oh, go ahead.
Okay. Second time's a charm. My name is Bo Wrights, a government affairs policy analyst with Providence Health Plan.
And hi, I'm Terry Cuffle with the American Orthotic and Prosthetic Association, also from Minnesota.
Hi, everyone. This is Nicole Verkeilen. I'm the Director of Impact Campaigns with the Amputee Coalition and the National Campaign Lead for So Everybody Can Move. A number of us, including myself, testified as advocates as part of this bill, and grateful to be on here with you all.
Hi, my name is Marlene Converse, and I'm a Senior Regulatory Consultant for Kaiser Permanente.
Good morning. My name is Scott White. I'm the Director of Regulatory Affairs, Samoda Health. Happy to be here. Thank you.
Hi, good morning. My name is Cheryl Sachs. I'm part of the National So Everybody Can Move initiative, and I'm based in Maryland. Thank you for having us.
All right. Anyone else who hasn't introduced themselves?
Hi, this is Ginger Avery. I am a coding review consultant from Cambia Health Solutions.
Hi, I'm Jamie Blevins, and I'm a policy and implementation senior with Cambia.
Hi, everyone. Anna Sovereign here. I represent the Northwest chapter of the American Academy of Orthotists and Prosthetists.
Hi, this is Larissa Sanders. I'm the supervisor of our policy and implementation team at Cambia/Regents Blue Cross Blue Shield of Oregon.
All right, so I think we got everyone. I know we also have Ashley White, who's running a little late because of a delayed flight, so we look forward to having her join. So yeah, we'll go ahead and get into this this meeting. So for some background, previously we would update our prosthetic and orthotic rule. We were required by statute to update it yearly. The original rule tied the list of devices to the CMS list for coverage. And we would update the year. So as of January 1st, 2025, January 1st of 2026 was our original proposed language for this rule. We did meet once early this year, but then during session, SB 699 came along and had some pieces that would change what our rulemaking requirement would be. So we paused the existing rulemaking to let that bill play out, and it did pass and was enrolled. And I believe everyone here should have a copy of it from the email or be familiar with it as you're part of this rulemaking. So the changes we identified that would impact this rule, there were a handful of changes in the bill, but the ones that directly impacted the rule we are talking about here, first was that it changed the definition. So it adds the definition of the term device to mean an orthotic device and a prosthetic device. So that would be the first section there. So device now means an orthotic device and a prosthetic device. And then we also noted that further down that it clarified that multiple devices would need to be covered if determined to be medically necessary and the most appropriate model that meets the medical needs of the insured for performing physical activities and that maximizes the insured's whole body health, including lower and upper limb function. The bill also listed some examples of physical activities, including but not limited to running, biking, swimming, and strength training. So this is the part where I will tell you that folks here at DFR are not experts on devices and what devices would be used in what situations. So then the bill also clarifies that DFR needs to, or maintains that DFR needs to create a list of these devices by rule. So we have a draft change. This is very early, just for discussion purposes. We expect a thorough, robust discussion here. So for the draft changes to 836-052-1001, the first change was to remove orthotic device and prosthetic device and just give that term device that's in the bill, put it into the rule here. And then the second was that we would update the year as we had previously planned. So as of January 1, 2026. So we'd still point to that CMS list for the L code for a list, but we would also add any additional devices that are determined to be medically necessary and the most appropriate model that meets the medical needs of the insured for purposes of performing physical activities, including but not limited to running, biking, swimming, and strength training, and that maximizes the insured's whole body health, including lower and upper limb function. So I guess I know that I sent this out, or we had this sent out a little late yesterday, but let's open it up for discussion. What are people's thoughts on what we have so far, or what are their thoughts in general? Yeah, Scott, go ahead.
Yeah, thank you. So for section B here, kind of just like it's done in section A, where you're not referencing specifics of coverage, you're referencing codes or another document that has specifics of coverage and associated codes. Would it make more sense just to reference the ORS that the Senate bill is actually amending? And that way, if at another time it's expanded or something along those lines via other legislation, you're not tying it to direct verbiage in a Senate bill. You're tying it to the verbiage that will be added to 743A, and that way it's just a little cleaner than having the medical necessity information here. It's not changing coverage parameters by any means, and where issuers are still following the past legislation. It just makes it a little cleaner.
Yeah, that's I mean, I think typically, and Jesse can correct me if I'm wrong, we don't often tie the rule directly back to a statutory citation. The other thing is we do, the statute does require us to update the list yearly. So it is something we'll be going and playing around with every year. But I do like the idea of keeping it clean. So, that is something we can look into. And Jesse, do we typically not like to do that, or are we good with tying to statute?
I think it might be a little confusing potentially to have to refer back to kind of have to have both documents in front of you to understand them. But I don't know, there might be some kind of drafting guidelines that we'd want to look at as far as how DOJ and others would recommend approaching this. But I mean, I think the approach we're suggesting is basically just plugging the statutory language into the rule text here. So, we're not looking at necessarily expanding upon it. Karen, if you're controlling the screen, I don't know if you could move down to the summary language. I think that, I don't know if that's in this document or in a different one, but I think that's what we're talking about at the moment.
So are we talking about the bill itself or the rules? I'm a bit confused with the two rules that I've got here.
Yeah,
there it
there
is.
you go. Yeah.
There it is.
That was
Gotcha.
me making your job. You don't have enough to do right now, so I wanted to make it a little.
All right.
All right. Thank you for the thought. Antoinette, I see your hand up.
Yes, and I'll go off mute. So my question, I have two things to address. So obviously for B, it does say any additional devices that are determined to be medically necessary. Again, I want to just make sure that the health plan is still also the one that is also determining the medical necessity aspect of these additional devices. That's my first point I want to make. And then the second one is in the bill, it goes also into detail about replacement of the device. And I believe that was some additional clarification that was sought by a carrier, somewhat to align with Washington's too. And I was just wondering if there's any intent to include some of that clarity in the existing rule. Because to me, as I'm reading Senate Bill 699, it addresses two things: clarification around our existing requirements, and then number two, the additional coverage for prosthetic and orthotics, specifically for those engaged in physical and athletic / sports activity.
Sure, thank you. Yeah. So for your second question, I think our interpretation of the repair replacement part section is that is pretty clear and doesn't necessarily require further clarification in rule. That the part that directly affects our rulemaking is just updating the list of devices covered. It doesn't really direct us to kind of hash out the replacement repair part. Again, it does have some good detail in the bill that we can always discuss that. But I think that's why we left that out, as it wasn't directly necessary for us to include in the rule. And I'm sorry, remind me of the first part, your first question.
Yeah, so the first part was if you read the changes in the draft changes under 2B, any additional devices that are determined to be medically necessary. I just want to confirm and assure that the health plan can also apply your medical necessity. We can use our medical necessity criteria as well.
Yes.
If I could jump in there, I think, I mean, it looks like you were probably going to say the same thing, but I think the way this is worded would basically apply the same kind of procedure here that would be applied to any ordinary medical necessity determination where the under a health benefit plan where a provider would make a determination on their end of the medical necessity of a particular item or service. There'd be a claim submitted or a request for prior auth or what have you, and then the carrier would be empowered to apply their own medical necessity criteria. And then if there was a dispute over that, it could potentially get appealed to ultimately an independent review organization. We recognize that this could result in, some disparity and differences in how things are handled. I think the difficulty is that we are not sure if there is a cleaner approach that wouldn't involve the division itself having to come up with a comprehensive list of all of the devices and when they ought to be covered, which is well outside of our expertise and purview. We'd be happy to consider proposals to address this differently or to point to existing lists that may be out there that are being promulgated by actual experts, but we just don't think we would be the ones that ought to be doing that.
Agreed. Okay.
That's exactly. All right. Thank you, Antoinette. Oh, you still have your hand up. Sorry, I think I did cut you off. So go ahead.
Oh, that's okay. And actually just thinking about all of this too, just also want to make sure that, with the additional language, I just want to make sure that this is all restricted again to the leg, foot, arm, hand, back, or neck, and not any other body part. I know DFR is not the expert, but I just want to make sure that we're all on the same page with respect to what it's confined to.
Yeah, I have a difficult time answering that question, except to say that I would assume that it would be similar to what's already in practice, just these additional devices. Nicole, I see your hand.
Yeah, I was just going to answer there. I mean, you said, I think you covered a lot of pretty much all body parts when you answered that. But the intention of the bill is about whole body health, and orthotics and prosthetics apply to the whole body. So in terms of your other question about medical necessity as well, that was the intention of our advocates, was to ensure that a provider is the one that is writing the prescription, and that is corroborated with a prosthetist or orthotist notes, but it still has the ability for the insurance carrier to review that. We included utilization management in the bill itself, but that it can't be denied for arbitrary reasons or for discriminatory reasons as well. And I want to make sure Ashley has the chance to respond as well.
Yes, thank you. Real quick, I'll just draw your attention. Sorry, Ashley, to jump in front of you. But Jesse did put into the chat the definition of orthotic device means a rigid or semi-rigid device supporting a weak or deformed leg, foot, arm, hand, back, or neck, or restricting or eliminating motion in a diseased or injured foot or leg, foot, arm, hand, back, or neck. prosthetic means an artificial limb device or appliance designed to replace in whole or in part an arm or a leg. So I don't think we'd be making any changes to that through this rule. We're just adopting the definitions that are already there.
Yeah, perfect. Thank you.
Yes, thank you. Ashley, thank you for joining. And I see your hand up. So I hope.
Yes, can you hear me?
Yes, we can hear you.
Okay. I just wanted to add to the comments about medical necessity. One of the reasons that the law was passed in the first place is because historically certain devices have been deemed not medically necessary by insurance carriers. And so in the nature of the law itself is to make sure that that practice changes. So I think while we, again, to Nicole's point, we wanted to make sure that utilization management and obviously the appropriate review process is in place for insurance companies to use, especially because we certainly don't want to. The worst thing would be for there to be a misuse of this, right? Like the whole point of rulemaking is to make sure that that the rules are followed and that there is no fraud and abuse. So I think we're all on the same page about the intention there. It's just important for physicians, for the providers to be able to, again, physicians who are not delivering these devices, right, to be able to prescribe them as needed for that individual.
Yeah, point well taken. And also, when you say fraud and abuse, also you're referring to the consumer itself too, because there could be instances of misuse and the mandate.
Certainly, we want to make sure that, I think we are all, the community is served best when, when we prevent misuse of the system. So to make sure that the people who need devices are the ones who are getting them. So
Exactly.
I think we're all on the same page about that.
Great. Thank you, Ashley.
Great. Thank you so much, both of you. Nicole, I see your hand up.
Yeah, I just wanted to speak to the kind of fraud and abuse and misuse portion of this as well. I think it's important to note that, these we're referring to, custom orthotic and prosthetic devices that take quite a bit of time for an individual to have made with their prosthetist and orthotist. These can take months to make, so there isn't a concern here in relation to fraud and abuse of the system and misuse of a device. I think that's an area that we were concerned with in terms of because individuals are utilizing these devices for high intensity activities, there is no misuse in a sense of a device that is part of your body. So I just wanted to make that point on behalf of advocates in terms of clarifying, like, how would we define misuse of a device?
Thank you, Nicole. All right. Any other thoughts? I'm looking and I don't see hands up. Obviously, I should have prefaced this because I try to whenever I do this, but we do, we welcome comments. It's not like if you don't say anything at this meeting, this was your one chance. So, we can leave this open. We do have other meetings on the books and everything like that. So I understand it's a pretty complicated one potentially. So, but I do want to keep this discussion going if people have more to talk about too. Yes, Jesse, I don't think you need to raise your hand, or at least you can interrupt me anytime. Yes.
Well, I don't know about that, but I just wanted to say, I think the biggest question we have about how to draft this rule is whether this approach of kind of layering on top of the existing CMS list this additional requirement that's basically just wholesale what's in the bill is the right way to do it, or whether we need to get more specific about what those devices are, or if there's some kind of external source where we could pull a list that would actually get at that, or clinical guidelines or something like that. Because I think this would implement the bill, but that it could create complications, and some lack of clarity in certain situations, and maybe that's just where we have to land. But I would really specifically appreciate any feedback one way or the other about that kind of approach, or other suggestions that people may have. We are aware that there are some other states that have passed similar laws, and maybe either have implemented regulations or are in the process of working on it right now. So if there are other state approaches that people would prefer that we look at or adopt, then we'd be happy to take a look at those as well. But I think that's kind of the biggest substantive question for the rule, is whether this is the right approach, or if we need to change tax in some way.
Yes, Scott.
Hi, Jesse. Yeah, good points, and thanks for calling that out. I guess, and this is, I would get out of my depth a little bit from a coding standpoint, but under A, any devices for which there is an L code or a HCPCS code, the devices being mentioned in B, to my knowledge, have those codes. I understand what we're trying to do, but is it absolutely necessary? And I'm not taking a stand either way to even add this part if those codes are included in A, but just knowing that since we're not, there was a reticence to reference statute, does it need to be addressed here at all? I'm just throwing this out, and would be interested in your comments, because A is technically what that bill changes. What the bill changes is just that these are now required for coverage, but we can still go through utilization review processes with them. So what does that actually change about codes listed in A?
Sure. Yeah, thank you, Scott. I saw Cheryl and Ashley both had their hands up. So Ashley, I'll go with you first, because maybe you can speak to Scott's question.
Actually, I think if Cheryl can go, and then I'll go
sure.
after her. She's a clinician, so she may have some coding ideas specifically. But well, actually, I'll just go ahead and share. I think from a clinical practice guidelines, if we wanted to reference, there are some established clinical practice guidelines specifically within the VA that may be useful in this regard. But Cheryl, do you have a coding comment?
Yes, thanks, Ashley. So kind of to build on what Scott was saying, the codes for these activity-specific orthoses and prostheses are not different than what you would see for everyday devices. It's the components that vary within those codes themselves. So I'd really kind of caution as to having specific devices in lists, because since these are customized, especially from the prosthetic standpoint, there's such a variety of code combinations that would be recommended for these certain devices. Again, so we're in Maryland. Maryland's law went into effect in January, and we haven't, we've been seeing a lot of success, but we haven't seen any restrictions on the codes themselves, just because they're already codes that are covered. It's just this another device itself that's being covered. If you are looking at the codes themselves, again, orthotics is a whole different ballpark than prosthetics. So if there are certain orthoses that are not covered in the legislation, such as an off-the-shelf device, perhaps that could be a code that would be excluded. But again, with these customized devices, there's really an infinite number of code sets that goes into the description of them.
Oh, thank you, Cheryl. Real quick before Antoinette, I was going to ask, Cheryl, you said you're in Maryland. Did they adopt a list, or just more of a general approach like this?
Yeah, absolutely. So Maryland approached a more generalized approach. There isn't a specific list with regards to the coverage for the and I will say Maryland is just prostheses. We don't have orthotic coverage for FTD-specific devices at this point, but it's really with the patient, seeing their clinician, seeing their physician or PA, and having that physician really establish the medical necessity as to why their everyday prosthesis does not provide enough benefit for the patient for them to be physically active in a safe manner for their whole body health. And then the physician, along with the clinician, is submitting again for that prior authorization to the insurance to get that coverage. So there is kind of that check and balance that Nicole and Ashley had alluded to before to make sure that these devices are medically necessary for that individual patient. So no, Maryland does not have a specific code list.
Great. Thank you for the clarification. I saw there, Antoinette, I see your hand up.
Yeah, and I from what I recall, because I participated in the first rulemaking for the prosthetics and orthotics when I think it was Senate Bill 797 became effective in 2024, and there was rulemaking. And I believe that carriers supported reference and use of the L codes because I think from what I understand, with the CMS codes, sometimes it was only restricted to those types of devices that are more that are more geared to the older population, and that I think carriers had no other reference point for the other type of devices for the younger population. So I think it was agreed upon that the reference to hip picks, I think L codes also be incorporated in the rules. This is what I recall from the first rulemaking, but it's been a while. Okay,
yeah,
that's all I wanted to add.
Thank you. Yeah, that I was not part of that first one, so
yeah, and I think several other people too were it. So thought I'll mention it. Thank you.
All right. Thank you. I'll go ahead and go Terry and then Cheryl. Unless you want to swap it, I'll leave it up to you guys.
Yes, happy to go. And actually, can you hear me? Yes. Yes. Okay, great. I'm actually build off of what Cheryl was saying. So I am from the state of Minnesota. Our statute for orthotics and prosthetics for recreational devices and showering and bathing devices became effective 1/1 of this year, 2025. Our statute is broad language like this is. It does not include a list. And the Minnesota Medicaid Department went one step further to help the O&P providers and consumer groups here in the state.
Sorry, you seem to be
going through the process. Can you hear me?
Yes. Yeah, I think you froze for a second, or did I freeze? I'm not sure.
Okay. Okay. The Minnesota Medicaid Department went one step further and brought in a small group, a task force group of O&P providers and consumers and administrators. And together we rewrote the policy for orthotics and prosthetic devices and incorporated the new laws into the policy. And when we were able to do that, we also used modifiers. The U1 and the U2 modifiers were brought into the policy. And for a first device, an everyday device, there's no prior authorization. For a second device, the U1 modifier is used, which would be for showering and bathing. And then for a recreational device, the U2 modifier would be used, and that would trigger a prior authorization. So if I didn't say it, the first device, everyday device, and the showering and bathing devices do not require prior authorization. The first does not require daily does not require a modifier. The showering bathing is a U1 modifier. And then the third device, which would be the recreational device, would be a U2 modifier is being used, and that would require prior authorization. So I believe it is the first across the states to go that in depth into the weeds, but I believe it's building off of what Cheryl said with lists, and it's also, I think, responding to one of the other questions that was brought up earlier today.
Great, thank you. Yes, that clarification is helpful. Cheryl, yeah, there's your hand. Go ahead.
Yes. Hi, yes, thank you. So I wanted to hopefully address part of Antoinette's question. So with the understanding of the different HCPCS codes and the L codes, so yes, the orthotic and prosthetic devices that are going to be covered under the new law are going to be L codes. I'm not sure if this is what you're referring to, but I'm not sure if you're referring to functional levels, which is also known as K levels. And so there are certain components that Medicare has said, unless a patient is a certain functional level, they are only, I guess, eligible, you could say, for a certain type of prosthetic foot or prosthetic knee. What would be challenging with relating that to this legislation is that not everyone with a certain K level would benefit from a secondary device. And people across different K levels might benefit from more than one prosthesis or orthosis under the legislation. Also, L codes and the functional levels are only for lower limb amputees. So it doesn't apply to any upper limb prosthetic devices, and it's not applicable to any orthotic devices. So I just wanted to add that in as you're considering what to include in the rules.
Thanks, Cheryl. But I think that functional level part will be part of medical necessity requirements as well. Just to note. Thank you.
Yeah, Scott.
Yeah, and just based on Cheryl's comment there, then I think that, and as Antoinette said, medical necessity would come into play. So I kind of take back my previous about kind of removing B. I think that actually is important based on what Cheryl's saying to have in the rule. So I would, I think I'll take back my previous comment about possibly removing that if they're all covered under A. So thank you, Cheryl, for that clarification. I think that B makes sense to be there based on what we're discussing. I also want to make sure we're not getting into utilization review and prior authorization in this rulemaking, because that's really not what in my mind, what this is meant to do, is to add additional things based on the Senate bill to this specific statute. I think that would be a totally separate rulemaking process. So I just want to clarify scope. Yeah, let me know if you have any questions on that, Ethan.
No, that makes sense. And yeah, we are not trying to do that, nor do we want to take on another rulemaking at this time. Yeah. Let's see. Any other questions? Any other comments? All right. So generally, again, we'll leave this open for feedback. It sounds like maybe the broader approach is effective this time. I do want to kind of the landscape of this. Usually a rulemaking like this, we would have started much earlier in the year. And we will next year, because we do need to update it yearly. We'll start it earlier so we have more lead time. With the session ending when it did, and with the bill passing and the effective date, we do need to get this rule done rather quickly. So there will be opportunities to see, year over year, how this is being implemented, how it's going, if there's tweaks, if there's changes we can make, what other states are doing. This is by no means closed. And in fact, by statute, it's required that we look at it every year and make changes. So that's something I just want to keep in mind. But with that in mind, Karen, can you remind me of when we have the next meeting on the calendar? And we haven't set the, sorry, it's just, we just actually kind of
yeah.
Time.
Okay.
I want to say it was August 3rd.
Yes. August 13 is what we are proposing for the next meeting. And correct, I have not sent that out.
No, that's fine. So we'll go ahead and get that invite sent. But in the meantime, unless I want to open it up the floor again, if anyone has any thoughts today while we're still talking. Antoinette, yes, go ahead.
Is there a need for another meeting though?
Well,
I was thinking maybe the next step, maybe comment period based on our discussions today. Just making sure. I don't know.
You're perfectly reasonable. You beat me to the punch. You've been at too many of these, clearly.
I've got like 8 going on right now. You got
we appreciate you, yes. No, I was going to give a comment period, give a date to get some comments in by, and if the comments are generally ones that don't require another meeting, then I don't know that we need another meeting. If there are comments that a group discussion, would facilitate, we have the time for that. So we would really want to make sure that we do it right. We started this as early as we could so that we would have some lead time to be able to do that. So I'm going to put the hold on your calendar just to have it there. And if we don't need it, then, it's like an early Christmas present or something, it's like, it's great. With that in mind, though, again, I don't see any hands. So what I'm going to do, I'm looking at my calendar here. So sorry. Let's keep a comment period open until Friday, August 8th, close of business. That gives everyone a little over a week to talk it over with your staff, your teams. If you want to share your comments to the whole group, you can. If you want to send them directly to like me and Jesse and Karen, you can. But just, let us know what you think. Let us know if there's anything you don't like or you do like, or just generally want to say hi. But otherwise, I can go ahead and give you some time back today. Does that sound good to everyone? You don't have to actually, but.
Hey, Ethan, I think we need to, though, do the public comment section.
Yep, you're right.
Of the agenda.
Yes,
just
you're right.
That we cover it.
Jump the gun. So do we have anyone from the public? Do we have any public comment? All right. Well, they will also have an opportunity later on to make comments. So with that in mind, close of business August 8th. We'll look for comments by then. And then we'll let you know as soon as we can the next week if we need another meeting or not. So fantastic. I thank you all. I appreciate your help. Everyone, it was very helpful, very interesting conversation, enlightening for me, at least. This is all very new. So thank you and have a great rest of the week.
Thanks,
you.
Ethan.
Thank you.
Thank you.
Thanks, everyone.
Thank you so much.